would like to acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of the First Nations, Métis, Inuit, and all First People of Canada, whose presence continues to enrich our vibrant community. We just had the Day of Truth and Reconciliation yesterday, and Orange Shirt Day here the day before, so I think that's a very timely topic. And we're very grateful to have Jia Lin today here to present on her exciting work that she has been doing for a few years now, I think, with Dr. Samantha Anthony in the Child Health Evaluation Sciences program at the Hospital of Sick Kids in Toronto. And we have been pleased to work together on a couple of things, and I'm sure we'll hear some very interesting updates on that work today that I find is extremely valuable, and pointing out some of the deficits that still exist around the world and in Canada in this relationship. So the title for today is Embarking on a Journey to Explore Pediatric Solid Organ Transplantation for Indigenous Patients, Families, and Communities. And I'll pass it on to you, Jia, if that's okay.
Perfect. Thank you, Dr. Urschel. Let me pull up my screen. Is everyone able to see it? Yes? Okay, so I'll start with my declaration of conflict of interest, and I don't have any to declare. And I want to say thanks everyone for having me and being here. I'm super excited to share a program of research exploring pediatric solid organ transplantation for Indigenous patients, families, and communities, and really walking you through this journey of co-learning and researching with Indigenous patients within transplantation. And as Dr. Urschel mentioned, I think this work is particularly relevant given yesterday was National Day for Truth and Reconciliation, as well as the 10-year anniversary of the final report of the Truth and Reconciliation Commission and their 94 calls to action. And I think it's a time for us all to reflect on what the last 10 years has looked like and how we can act more towards reconciliation and health equity with Indigenous peoples. I'd also like to acknowledge our funders and supporters, so Canadian Blood Services, CIHR, and the University of Toronto Leong Centre. And I'll also start with a land acknowledgement coming from Toronto and the Hospital for Sick Children. So as a settler, acknowledge the land that the Hospital for Sick Children resides on, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Nishabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Métis, and Inuit peoples. I say this land acknowledgement respectfully to honor the rich Indigenous governances that have existed, that are ongoing, and that will continue into the future. And for me and our team, this acknowledgement reminds us that we are accountable to our relationships with diverse nations, the lands, the waters, the animals, the elements, and that many of us as settlers continue to benefit from this land that we live, play, learn, and work on. And so we keep this acknowledgement close to our hearts. This is the objectives of today's talk. So develop a deeper understanding of the ethical and relational responsibilities of doing health research with Indigenous populations, explore the role of patient and community partners in co-designing culturally relevant research in pediatric solid organ transplantation, and present preliminary findings from a multi-phase research program exploring the experiences of solid organ transplantation for Indigenous children and families. And as an introduction to myself and my lab, or our lab, my name is Jia, and I'm a clinical research project coordinator, and I've been working with Dr. Samantha Anthony, who's also on this call, for over 5 years now. And within Dr. Anthony's lab, our collective research goal across our projects aims to examine the biopsychosocial impact of pediatric transplantation on patients and families, and to improve health outcomes by transforming clinical practice. So what really draws me to this work is the emphasis on health in a holistic manner, so not just the absence of illness, but also the psycho and social and emotional elements of well-being. And so I wanted to highlight 3 pillars here of Dr. Anthony's program of research. So first, engaging patients meaningfully, focusing on patient-identified priorities and integrating their experiential knowledge through patient-centered partnerships. The second here, capturing the patient's voice, so exploring the transplant experience from the perspectives of those who live it and create meaning from it. And third, advancing implementation sciences, so promoting the development, evaluation, and systematic uptake of innovative evidence-based interventions into clinical practice. So really patient-oriented and patient-engaged research based on their needs and priorities is the foundation of our lab's research, and I think really sets up nicely the context of our study with Indigenous transplant patients and families. I also wanted to introduce our research team or circle, as is customary within many Indigenous cultures and in Indigenous research designed to introduce and locate ourselves as a sign of respect, and as well as to maintain authenticity and transparency in the research process. So our team is comprised of patient partners, researchers, clinicians, from 4 pediatric transplant sites across Canada, so Sick Kids in Toronto, BC Children's Hospital in Vancouver, Soy Children's Hospital in Edmonton, and Winnipeg Health Science Center. And I'd also take a moment to acknowledge and honor the late Mary Bocage, who's the first name here on this list, who really was the catalyst of this project. And some of you might know who Mary was. She was an Anishinaabe from Nipissing First Nation. She was a co-principal investigator on this project, as well as a patient partner, having received a kidney transplant herself. She was also an advocate for kidney organ donation and transplantation, and a champion for Indigenous health and weaving Indigenous ways of knowing and ceremony into health research. So she's really a catalyst for this research in terms of centering the voices of Indigenous patients and families in transplant research. And her passing has left a huge hole in our hearts and on our team, and we really wanted to honor her legacy as we continue this research. And for myself, I think it's also important to locate myself as a non-Indigenous settler researcher. So I've been involved broadly with Indigenous health research for about 6 years now. My background really is in public health, and my master's really focused on exploring Indigenous cultural safety training within graduate public health education. And I know as health researchers, we know that Indigenous health equity is something that we are really lagging behind on. So I'm super honored to be doing this research along our team and our Indigenous partners, and working collaboratively in ways that reflect and respect our shared goals. A little bit of background. Indigenous children, including First Nations, Métis, and Inuit children, are the fastest growing cohort of children in Canada. But despite this, they continue to face persistent health and social disparities. And when I refer to Indigenous peoples here, I am using this term as an inclusive term to describe individuals and collectives who identify as being related to or having a historical continuity with First Peoples of the land. And we deliberately chose this term, Indigenous, to support the assertion for self-definition, while also recognizing the cultural, historical, and political diversity among Indigenous peoples in Canada and globally. So being intentional not to use a pan-Indigenous approach, which can often overlook the unique experiences and challenges faced by specific communities and collectives. With that being said, the health and social disparities faced are quite multifaceted and complex, with upstream factors linked to Canada's ongoing history of colonialism, including land dispossession, discriminatory government policies, anti-Indigenous racism, that continue to perpetuate the structural disempowerment of Indigenous peoples and communities, including affecting access to resources such as in healthcare. So in the area of pediatric transplantation, Indigenous children have reported experiencing disproportionately higher rates of kidney, liver, cardiovascular, and respiratory diseases. And these conditions can progress to end-stage disease, requiring transplantation at higher rates. So transplant is considered the ultimate treatment for children with end-stage organ failure. Compared with other life supportive care options, transplant is often associated with improved clinical and patient-reported outcome measures, so including increased life expectancy, quality of life, and decreased patient and health systems cost. but undergoing a transplant is a complex process, including an initial referral to a transplant center for pre-transplant education and evaluation. Following transplant, patients must adhere to a strict regimen of immunosuppressant drug therapy and lifelong medical follow-up, so clinic visits, tests, procedures, amidst possible other health challenges, and the risk for severe adverse events. And the barriers for patients and families proceeding through each of these stages are quite multifaceted, especially for Indigenous patients and families who often encounter other structural vulnerabilities compounded by a general lack of culturally safe care in the healthcare system. And I mentioned the Truth and Reconciliation Commission earlier, but they released their 2015 final report following years of information gathering and public discussions with residential school survivors. And one of the key outcomes of the Truth and Reconciliation Commission was the creation of 94 calls to action. So these calls to action were designed to address the ongoing legacy of residential schools and to chart a path forward to reconciliation. So they define this as ongoing process of establishing and maintaining respectful relationships between Indigenous and non-Indigenous Canadians. So a particular relevance to our work is Call to Action 19, which states, in consultation with Aboriginal peoples, to identify and close the gaps in health outcomes between Aboriginal and non-Aboriginal communities, and to publish annual progress reports and assess long-term trends. And such efforts would focus on indicators such as infant and child health issues, chronic diseases, and the availability of appropriate health services. And so this call has really guided our project here. And having the Truth and Reconciliation calls in mind, the overarching objective of our program of research is to advance child health equity by improving access to and health outcomes of pediatric transplantation among Indigenous patients and families. So we are exploring the following research questions. How can we foster meaningful engagement with Indigenous patients and families as equal partners in health research? What is known about the need for access to and health outcomes of transplant among Indigenous children and families? What are the healthcare experiences, stories, and perspectives of Indigenous patients, families, and shareholders? And how can we create synergies with community partners to create culturally safe tools to improve health outcomes in pediatric solid organ transplantation? And so I'll be kind of walking you through these 4 questions, and I'll start first with this first question: how can we foster meaningful engagement? And so I talked a little bit about the inception of this research, working with the late Mary Bocage in developing this research project and centering Indigenous health in transplant research. And I think mainly as a team of mainly non-Indigenous researchers and clinicians, there were particular considerations that we had to recognize to engage in ethical and meaningful Indigenous health research. And I've heard time and time again that research can be a very dirty word for many Indigenous peoples, based on the history of unethical research conducted on Indigenous communities rather than with Indigenous communities. So stories of, helicopters researchers who swoop into communities, collect their data, and then leave without that research ever reaching back to the community. Or also stories of non-Indigenous researchers kind of silencing or misappropriating Indigenous voices and stories. So I think communities have felt quite apprehensive of research or distrustful of research. And so with that in mind, that invited us to consider the possibilities and opportunities of researching with Indigenous peoples in a meaningful way. So not just that the outcomes of research were meaningful, but also that the process of research would also be meaningful. And for us, that meant unlearning and relearning these taken for granted assumptions of biomedical research. And so here I've highlighted a few considerations and learnings that we engaged with as we started this research journey, and knowing that this is a lifelong and continuous learning process. So first is the recognition of Indigenous peoples and of colonial realities, so that they have lived on these lands for millennia. They have diverse cultures, languages, and knowledge systems important to health and well-being, and that we can't really talk about equity and disparities without also talking about the impacts of colonization that continue to manifest to this day. So I think acknowledging these realities really challenges us to approach this work with more humility. Second is knowing that there are research ethics and protocols specific to Indigenous health research. So some of us might be familiar with the Tri-Council Policy Statement, Chapter 9, research involving First Nations, Inuit, and Métis peoples, which outlines some key concepts and definitions around engaging with Indigenous participants. And some communities or collectives might have their own frameworks and protocols to ensure that researchers understand and respect cultural practices when engaging with this work. Next is that research must support Indigenous self-determination and governance. So Indigenous people have the right to lead research that concerns their health, priorities, and aspirations. And for us, this meant decision-making at every stage with our Indigenous partners, from formulating the research question to interpreting the results, determining even how these findings are then shared, and really having ownership of the research. And then lastly, I wanted to highlight what Kirkness and Bernhardt describe as the 4 R's of engaging with Indigenous peoples in research. So respecting Indigenous knowledge systems, traditions, and perspectives as equal to Western paradigms. And respect also invites deep listening and treating Indigenous peoples as co-researchers, not just as participants. Relevance, so making sure that the research addresses priorities identified by Indigenous peoples. So this might involve tackling health challenges in ways that align with cultural frameworks and practices. Reciprocity highlights the importance of mutual benefit. So research should give back to Indigenous communities, whether through capacity building, tangible resources, or actual outcomes that improve health and well-being. And then responsibility. So this calls for us to act ethically and to uphold commitments and remain accountable to Indigenous peoples throughout the research and beyond. And there is a 5th R that is incredibly important and really the center of our research, which is relationship building and forming relationality with our partners. And I think we really spent the first 2 years of this project and have continued since then, trying to build a strong foundation of relationships with Indigenous partners in the transplant space. So reaching out, building relationships with our shared goal in mind. And this has not always been an easy process. It really takes time, commitment, I think, and a general humbleness in acknowledging that we are not the experts, but rather our Indigenous families are. So we established an advisory committee comprised of mainly First Nations and Métis patients and families with lived experience of transplant. And so from conception to dissemination, we have been engaging, supporting, collaborating, and empowering our advisory committee partners to co-lead the research process such that findings can be the most relevant and meaningful to them and their respective communities. To facilitate a relationship, our team has been taking part in the Wabishki-Bichigoshganj learning pathway of self-reflection and dialogue to build, cultural safety and learn ethical ways of researching with Indigenous populations. So this learning pathway was co-developed by members of Indigenous-led council at CanSolve CKD, which is a national kidney disease organization. And Wabishki-Bichigoshganj means white horse in Anishinaabe, and was actually suggested by the late Mary Bocage as a framework or a guide to follow to support meaningful collaboration in health research with Indigenous peoples. So I've added a QR code here if people are interested in learning more about this pathway. But it contains several key components, which are outlined here. So land acknowledgement series, Kara's blanket exercise, Sonya's cultural safety training, etc. And at its core, it really emphasizes co-creating research processes with Indigenous peoples and ensuring that Indigenous voices, values, and sovereignty are upheld. And so our team has been kind of working through this pathway, being careful not to use it as a check mark to cultural safety, but more as a way to facilitate engagement and relationship building with our advisory committee members and also within our team. So these are just some more images of the activities that we've done. We did the Kairos blanket exercise back in COVID, so you can see some of us on the Zoom screen there with our backgrounds. Sonya's cultural competency training, OCAP training, and other activities on the learning pathway. And I think the key part I wanted to emphasize here is that relationship building really takes time and patience, and should begin from the onset of the project. This was done kind of at the beginning when we didn't even have participants yet. But sometimes this piece of relationship building can be quite antithetical to how we traditionally do research in the biomedical space. So I remember in the earlier stages of this research, we were applying for a bunch of grants, and we had reached out to our partners for their CV, a 5-page bio sketch. But it feels sometimes out of order to be talking about, can you give me all your academic and employment background without asking more about our partners' personal and everyday lives and experiences? And so when I say that, relationship building takes time, it means that sometimes our meetings with our partners, the first half is just talking about, how we are, how life has been, catching up, how are their children, versus trying to get through all the meeting points in our meeting agenda. And so sometimes we don't check every single box, but we still kind of out of these meetings knowing a bit more about each other, and sometimes that is more valuable to our project. So going back to our research objective, advancing child health equity by improving access to and health outcomes of pediatric transplantation among Indigenous patients and families. And I'll move on to the second research question here. So what is known about the need for access to and health outcomes of transplant for Indigenous children and families? And we took essentially a 3-phased research design approach where each phase builds upon the previous phase. So this includes a scoping review to characterize international landscape and identify knowledge gaps relating to access, survival, and health outcomes of transplant among Indigenous children. So this was completed last year. Phase 2 is qualitative interviews with Indigenous patients and families to elicit their stories and experiences of the transplant and identify system-level barriers and facilitators to improve care. And this phase is ongoing. And then phase 3 is knowledge sharing. So sharing findings with partners and shareholders to support kind of this dynamic and iterative process of maximizing impact and outcome. And as mentioned, we are partnered with 4 pediatric transplant sites across Canada. So I'll start with a phase 1. We conducted a scoping review to characterize the international landscape and identify knowledge gaps relating to access, survival, and health outcomes for Indigenous patients in settler colonial states. So these states included Canada, United States, Australia, and Aotearoa, New Zealand. And we focus on settler colonial states because we found a significant gap in the Canadian literature on this topic. So we expanded our scope to include international research to allow us to draw insights and comparisons from other contexts with shared colonial realities. Our scoping review included the following Indigenous groups: so First Nations, Inuit, Métis people of Canada, Maori people of Aotearoa, New Zealand, Aboriginal and Torres Strait Islanders peoples of Australia, and Native American and Alaska Native peoples of the United States. And in terms of participants, we looked at Indigenous children. The concept was characteristics of access to care and health outcomes. And then, as I mentioned, the context were the 4 settler colonial states. And we conducted this scoping review in collaboration with our patient advisory committee, who were engaged across several research processes. So this included co-developing the search strategy. So what were some appropriate terms that we should use in the search strategy, sharing feedback on results and interpretation, reviewing and editing the final manuscript that was published, and being named authors on the publication. So this is some of the findings, and I won't bore you with some of this data, but we had 24 studies published between 1996 and 2021 that were included. Studies address Indigenous populations within the United States, Canada, Aotearoa, New Zealand, and Australia, and Aotearoa, New Zealand, and Australia combined. And most articles used a retrospective cohort design, so like a database review for their data. Articles included kidney, so 13 articles, liver, 10 articles, and 1 article focused on heart organ groups. And there were no articles that included participants across multiple organ groups or addressed lung or pancreas organ groups. We categorize our findings based on organ groups, so kidney, liver, and heart transplant. In terms of kidney transplant, our findings identified health disparities for Indigenous pediatric patients with kidney failure, with Indigenous patients experiencing longer duration on dialysis, lower rates of preemptive kidney transplantation, which is often the preferred modality of kidney replacement therapy, and Indigenous children were also less likely to receive a living donor kidney transplant. So, for example, there was one study that reported the First Nations pediatric patients were less likely to receive a kidney transplant from any source, including from a living donor, from a deceased donor compared to non-First Nations patients. In addition, several studies also documented differences in long-term kidney graft outcomes and patient survival, showing poor outcomes for Indigenous patients compared to non-Indigenous patients following kidney transplantation. Turning to liver transplantation, the findings for liver transplant were actually quite mixed. So among pediatric patients with liver failure, some studies found that Indigenous children were overrepresented in the liver transplant population, while other studies found that they were underrepresented. When it came to graft outcomes and patient survival, studies reported pretty comparable outcomes among Indigenous and non-Indigenous patients. So for instance, one study published in New Zealand found that all children who received a liver transplant, including Maori children, were reported to be living at home, attending school, kind of reflecting favorable post-transplant outcomes. And then in terms of heart transplant, the article on heart transplant, the literature was quite sparse, and there was really no data on access to heart transplant, with limited data on patient and graft outcomes in this population. We also explored the social determinants of health that may impact access to and outcomes of transplant for Indigenous children, and we identified three main categories. So geography and relocation, lack of cultural safety, and a shortage of suitable or well-matched organ donors. So in geography and relocation, our findings identified a greater proportion of Indigenous children live further from pediatric transplant centers or in more remote locations. And one article in Australia found that the remoteness of residence was a sole predictor of death and retransplantation for pediatric liver transplant recipients, with increased rates observed among First Nations Australians patients from remote areas. And the lack of specialized medical support in remote communities is a well-known barrier in accessing healthcare for Indigenous peoples. Indigenous patients living in remote communities often have to relocate to an urban center to await transplantation, leaving behind their cultural support systems while facing additional financial stressors, both affecting their transplant experience and subsequent outcomes. Lack of cultural safety. So the limited integration of traditional knowledge, healing practices, and ways of being into Western healthcare systems was another identified key determinant. So, for example, one study highlighted that traditional spiritual beliefs about transplantation influence the acceptance of transplant as life-saving therapy. And I think this really underscores the need for culturally safe and inclusive care models for patients and families. And then shortage of suitable donors. So lack of suitable donors was also identified as a determinant. Studies noted that finding a suitable donor organ were critical issues for Maori and First Nations Australian patients, resulting in fewer transplants for this population. As well, there are disparities in graft outcomes for Maori kidney transplant patients that were linked to the limited availability of living donors or well-matched deceased donors. And we know that in the adult literature, Indigenous patients have reported that pursuing preemptive or living donor transplant is complicated by a reluctance to accept an organ from a family member or community member, concerns that the donor may experience negative health outcomes afterwards, and a real need to integrate cultural practices within the transplant experience to honor the donor. So for example, having smudges or healing circles. And I think these are all areas for further exploration within the Indigenous pediatric population. So overall, our review highlights several evidence gaps in the existing literature on pediatric transplant for Indigenous populations. So the first was a significant omission in discussing the impacts of colonialism or intergenerational trauma or institutional racism on the impact of access and outcomes, which can be critical barriers that really shape the healthcare experiences for Indigenous populations. Our review also identifies substantial gaps in evidence related to heart, lung, pancreas, and multi-organ transplantation for Indigenous populations. Lack of focus on patient-reported outcomes, such as quality of life. Lack of strength-based perspectives that really emphasize resilience and well-being. And that research methodologies tended to be kind of database reviews, and there's a lack of focus on community-based or participatory research approaches. And I think only one of the articles explicitly reported working with Indigenous partners. So that being another key gap in the existing research. And then in terms of future research considerations, the need for research within local community-led contexts, an acknowledgement of the interconnectedness of social determinants of health, colonization, and transplant outcomes, and a real need for community-driven approaches for culturally safe healthcare delivery. And so our scoping review was published in 2023, and I have a QR code if people are interested in taking a look at it. And then we also created this infographic to convey the findings for a more lay audience. And we're happy to share this also with anyone who is interested. So going back to our research questions, we'll move on to the third one now, which is what are the healthcare experiences, stories, and perspectives of Indigenous patients, families, and shareholders? And this right here is phase 2. So the interview stories, which I'll be sharing now. And so this phase is a multi-site qualitative study aiming to capture the stories and voices of Indigenous patients and families, as well as healthcare actors around their transplant experiences, and looking at barriers and opportunities to enhance care and outcomes for this population. And so we recruited participants across 4 sites: SickKids, BC Children's Hospital, Stoller Children's Hospital, and Health Science Center Winnipeg, where participants were invited to share their transplant stories via in-depth, open-ended interviews. And this phase was really co-developed with our patient partners, especially the late Mary Bocage, who emphasized the importance of stories as a knowledge-sharing tradition in many Indigenous cultures. So I remember something that Mary said early on as we were conceptualizing this phase was Indigenous stories are our strength, and storytelling as a strength-based approach for understanding healthcare experiences. And even from phase 1, our scoping review, we see gaps in the existing research that it's mainly based on quantitative retrospective database studies that often compare Indigenous patients with the status quo, and that findings are often reported as disparities without acknowledging colonization or the strengths of Indigenous communities. And so this phase really aims to address many of these existing evidence gaps by centering Indigenous voices and their stories on their own terms. And I think the power of storytelling can be quite multifold. So stories can transmit and sustain knowledge, it can reinforce Indigenous knowledge systems, and can oftentimes contain a lesson or a teaching for the recipient of the story. So we completed 25 qualitative interviews or storytelling interviews with 30 participants. 8 were patients and 22 were parents or caregivers. And we also had 4 healthcare actors. Experiences comprised, so 48% were related to kidney transplant, 22 heart, 19 liver, and 11 had experience of small bowel transplantation. And the interviews were semi-structured, open-ended, and really guided by participants and what they felt was important to share in their experience. And in terms of qualitative analysis, we've been following Joanne Archibald's story work principles of respect, responsibility, reverence, reciprocity, holism, interrelatedness, and synergies, and actively collaborating with our patient partners around these findings and interpretations. And as a foundation of this analysis, so I mentioned Joanne Archibald's 7 SORC principles. We use this as a way to make meaning from the interviews. So Joanne is, she's a scholar from the West Coast in British Columbia. Excuse me. And so the first 4 principles really surrounds the ethics of engaging with Indigenous stories. So very similar to the 4 R's of research mentioned earlier. So respect for the people who owned and shared the stories, responsibility, so carrying out research in a responsible manner, responsibility of the stories and their accuracy and authenticity. Reverence, cultural knowledge embedded in stories, so stories of ceremony. Reciprocity, so giving research back to community, sharing learnings with others. And then the last three principles are more around how to interpret or make meaning from the stories. So holism, so the intellectual, spiritual, emotional, and physical aspects of stories and how stories may connect with family, community, and nation. Interrelatedness, so the interrelatedness between the story, the storyteller, and the listener, and how all of our life experience shape each other. And then synergy, so the power created during storytelling with emotional, healing, and spiritual aspects. So broadly, I'm going to be presenting the 7 key story threads that have consistently emerged across family stories. And each of these threads represents kind of a spectrum of experiences. And as individual stories may weave across these spectrums and layers, reflecting the complexity of patients' and families' journeys. So the first is identity and community, and that Indigenous peoples hold unique and diverse relationships with their cultures. And this first thread really forms the foundation of many stories. Participants oftentimes introduce themselves, their background, their community, their histories, and shared a spectrum of relationships with their identity and community, ranging from strong cultural ties to experiences of being urban Indigenous and moving frequently or feeling displaced due to colonization. For many, there are also powerful narratives of reclaiming and re-owning their identity. And among those who lived on reserves or rural or remote communities, there was often this connection described with the land in great detail. So in language that conveyed more than just a physical location to live on, but also a medical, physical, or a spiritual entity to live with. The second thread, accessing healthcare, can be challenging. And in discussing experiences with the healthcare system, even before the topic of transplant came up in interviews, were the challenges of accessing basic healthcare for many Indigenous peoples. So this was particularly salient among participants who lived in rural or remote communities, where they may have had only a local clinic or a clinician coming into the community once or twice a week. And some participants noted that clinicians who came in were often not trained on specialized care, along with a lack of equipment for testing. And in addition was a general perception among participants of discrimination or racial discrimination within the healthcare institution. So staff and clinicians having assumptions, perceptions, or negative stereotypes of Indigenous peoples. And collectively, this ultimately manifested in some patients and families, especially younger parents, receiving inadequate or delayed care. And even one of our participants describing herself being failed medically by the healthcare institution. The third thread is the importance of relational care. And patients and families often describe traveling to larger urban centers for diagnosis, treatment, and transplant follow-up. And for many patients and participants, this was described as kind of a cultural shock. So being away from family, community, their culture, and feeling very much unfamiliar with healthcare spaces. This was often contrasted to the holistic perception of health that many patients and families emphasize and were familiar with. Some participants also shared difficulties in communication, inadequate communication with healthcare providers. So, for example, speech filled with medical jargon that was difficult to understand. There was also experiences of difficulties navigating the healthcare system. So a common description of Indigenous invisibility, so not being seen, not knowing what was available, what sort of resources or support was available for them, and a general lack of Indigenous specific approaches to care. The fourth thread is the decision for and experience of transplant. So this period between diagnosis and transplant is often described for many participants as a very intense period. And many participants actually skipped over it sometimes, and we really had to probe for more detail. So for some participants, transplant was brought up very early in the conversation as something that was inevitable. For others, transplant was something that was to be avoided, with procedures performed to prevent transplant as a last resort. The perception among most of our participants was that transplant was life-saving and that it was accepted and wanted. But again, the majority of our sample had received a transplant. Some families pondered the spiritual implications of transplant on whether it conflicted with their traditional or spiritual beliefs, but ultimately decided that if it was there, then Creator had meant for it to be there. Other participants saw transplant as the only way forward for life. And organ donation was also a very complex discussion. So for some, family and friends volunteered, yet the donor criteria made it difficult for many family members to donate a living organ. So for example, the BMI and perhaps comorbidities. And there was also an overall awareness that donation was a big ask and a burden for family and community members, with an awe and thankfulness to donors. So the fifth thread is transplant structural barriers, and participants describe numerous structural barriers shaping both access to and life after transplant. So families often face major disruptions due to geography, living in rural or remote locations, and having to move closer to urban centers to await transplantations. Some parents, particularly younger parents, were forced to abandon education or employment to provide full-time care for their child in the city. Financial strain was another constant pressure. And as mentioned, Indigenous families highlight experience of Indigenous invisibility in the healthcare system, so not knowing what kinds of supports or resources were available to them. And even when connected to financial support organizations such as Jordan's Principle or NIHB, there are also sometimes significant administrative delays or kind of burdens for them. So, with all of this, the overall landscape remained very fragmented and difficult to navigate for many patients and families. The sixth thread, advocacy and resilience. So many family members describe the steep learning curve of navigating the healthcare system, and also having to advocate fiercely for their children in the face of unequal care. There are many accounts highlighted the importance of healthcare champions, so healthcare providers who not only delivered, medical expertise, but also offered compassion and emotional support and social support to participants as champions. Beyond the clinic, families also emphasized the critical role of broader community networks, whose encouragement and solidarity and support really helped them through their transplant journey. And lastly, the desire for safe and inclusive care. So this final thread really reflects a widespread desire for care that fosters safety and belonging. So families emphasize the importance of hospital spaces where Indigenous patients and families could ground themselves, could be supported by elders and knowledge keepers. They also called for greater Indigenous representation within healthcare teams, as well as more integration of traditional and Western medicine. So to be able to have access to their own knowledge to complement transplant medicine. Participants also stressed the need for relational communication, anti-Indigenous and cultural safety training for healthcare providers and staff. And these changes were often seen not only as supports for individual families, but also towards a step towards empowerment and the promotion of Indigenous-led health initiatives. So in terms of healthcare actors, we only interviewed 4 healthcare actors, but the key message really pointed to a need to heal fragmented relationships between Indigenous communities and healthcare systems. So this one quote was really poignant to us. And this person said, "We need to start to somehow dismantle the fragmented relationships with the healthcare systems. So relational engagement is going to be important. There needs to be some sort of reconciliatory process to bridge that gap." And I also wanted to highlight the dual role of storytelling as both a healing practice and a form of ceremony. So many participants emphasize the importance of story, of sharing their own story and their child's story through this methodology. So here, the act of storytelling was not just recounting events, but also became a personal and relational process. So not merely conveying the contents of their story, but also communicating their experiences through the way they told their stories, their tone, rhythm, and choice of words reflected in their journey. And so I have a few quotes here from participants. "This is my favorite story because everything just came together like it was meant to be. It's healing. Up until last year, I couldn't talk about my son's transplant. I barely said it. So it's healing in a way now for me to be able to do that." Another participant said, "As a ceremonial person, we feel the emotions, we feel the energy, we feel the creator. I can talk about my daughter without crying. She's with me all the time. Her teachings, her guidance, that's what keeps me going to look after my other kids. The strength she gave me about life. Another participant shared, just seeing my daughter get better, get her hair back, her strength, such an experience, like life-changing too. I tell her story to everybody. I know people tell me, you give me goosebumps when you speak about your daughter and her story. We could have lost her, but now they've brought her back. I will always tell her story. And lastly, one person said, I believe in sharing my story in order to facilitate change. So really kind of affirming this methodology in this project. So I'm mindful of time, and I'll go through the last research question here, which is how can we create synergies with community partners to create culturally safe tools to improve health outcomes in pediatric transplantation. And this here is the final phase, which is kind of what we're starting with now till next year. And originally we had envisioned this as a knowledge sharing workshop. So to share research findings in a meaningful way with various partners, participants, and stakeholders. But as we talk to our participants and partners, we realized that this workshop might not be the best approach. Participants really emphasize having something tangible from this research, having something they could hold on to, that they could see, that they could kind of share as well. So we've been exploring some arts-based approaches to sharing research findings. So one is digital storytelling videos. So co-creating these videos with our patient and family advisory committee to share stories in ways that can really reflect their experiences. Another kind of idea we've been playing around with is a collaborative artwork or beadwork that we could create with our collaborators to have and perhaps display at each transplant center as a reminder of this project and patient stories. So we're still kind of navigating, what the next step is, but definitely stay tuned to see what comes out of this. And this is my second last slide. It really is about impact and future direction. So with a better understanding of the lives, cultures, stories, and experiences of Indigenous patients and families, we hope that healthcare institutions can move towards improving access and care for this population. We hope that these findings directly address the Truth and Reconciliation Commission's call to action, especially 19, and that ultimately this research has been and is a co-learning journey, and it sets the groundwork for future phases of community-based research to explore the realities of transplant for Indigenous patients, families, and communities. So with that, I'm going to say thank you, especially to our patient advisory committee, especially to our participants who have shared their stories with us. Thank you to our funders, our collaborators, and our research team. And I'll open the floor to any questions.
Thank you so much, Jai. That was very insightful. And I first want to use the opportunity to really congratulate you and your team for the approach that you chose here, because it's quite novel and different. And there's so much to learn from both sides and so much different views. And it's such a complex, multi-layered issue because it's not just Indigenous heritage. It also goes along with living very remotely, not having access, not being able to be flown out in a day if something happens, and so on. We face those challenges every day. I think everybody can send their questions either through the chat or just raise your hand and then unmute yourself to ask the question, which is probably the easier way. While we're waiting for people to ask question, one that I had for you is, which you already mentioned a bit, around your knowledge distribution within the community. And I was wondering, because also I noticed through the project that it was sometimes difficult to engage people from the First Nations communities in the same way that you would expect from people that are maybe more used to it. And so do you have any kind of clear knowledge translation plans specifically going into the communities where there may be future families that would benefit from it, so that they feel more encouraged to participate, but also to be heard from the clinical side?
Yeah. Thank you for your question. We've been exploring various different kind of sharing initiatives targeted at, different partners. And I think we're being really mindful of trying to align what we create that will be well received from patients and families and community members. So Part of that is making these findings more accessible to them. So not everyone is going to be reading, a manuscript or being able to attend rounds like this. It's kind of a quite an exclusive group who's able to access that knowledge. And that's why we've been focusing on things like short videos that we can create and share through even YouTube or through maybe links of the organizations I could share with patients and families in ways that they're able to, watch a video and kind of still understand. And one of the things that has come from this research and interviewing and participants is that when they kind of hear that there's other participants in the study, they're like, oh, we've never been connected, but now we feel a little bit less alone, knowing that there's other stories out there and feeling that connection. So I feel like with the storytelling videos that we're hoping to create and sharing them, through our institutions with families and patients, but also through our partners, for them to also distribute to various organizations that can reach our target kind of audience is what we're hoping to achieve in terms of making it very accessible to them.
Fantastic. Do people have questions? Please raise your hand, or don't have anything in the chat. And I want to apologize again for the technical problems that probably kept some people off. We will follow up with that and check to improve that for the future. So sorry, Jai, that it
That's
hit you
okay.
really quick. Along the knowledge translation question, I think it would be very much appreciated from all of the centers that have participated, and probably also from the ones that may not have been able to participate, to get respective feedback, as you suggested, to have something that we can put up in our clinic, that we have a pathway we can connect our families to, so that they can see, okay. And we do that a lot anyway, right? Like when we have a new family, because they're all facing these terrible changed plans to their lives as compared to before. And we often offer them to be hooked up with another family that has gone through this 10 years ago and now is doing well. But having this coming from a similar cultural background would be extremely helpful. So if there's a resource, a way to share resources would, I'm sure,
Yes.
be greatly
Yeah.
appreciated from all centers.
I think connecting families who've, are going through or have gone through this experience is, in a way, helps with the isolation feeling for a lot of families, like regardless of culture or background. But I think especially because the population is so small for Indigenous patients and families to be able to meet someone else. And that's where I think a lot of our participants have talked about having a space within hospitals that they could kind of go and ground themselves and decompress from, maybe the very clinical space of the institution, where they could meet other families and they could kind of practice cultural practices that they want to. And I know some institutions now have started building or implementing these kind of spaces where people can smudge or people can meet with an elder or knowledge keeper. And I think that is something for sure that our findings kind of affirm in terms of like creating this space and fostering a bit more belonging into this system that for a lot of people, they're not familiar with this.
Great. We have one question in the chat, which goes into a similar direction, from Sarah. If you want to ask it yourself, feel free. Otherwise, I'll just read it. It's, how do you envision that Indigenous peoples will get more information on which support options are available to them?
I think the role of health navigators is really important here, and the role of social workers. A lot of our participants and families talked about like healthcare champions. And a lot of these were health navigators or social workers who not only focus on the medical aspect, but also on the social aspect, the emotional aspect, connecting them to resources such as Jordan's Principle or NIHB. And for some of these families, they didn't know that there was these options available, that they could apply to this organization and they could receive financial support in this way, or that there was maybe a room that they could go to, they could stay overnight. So I think, now SickKids, we've had a health navigator for I think 2 years now, but even like increasing recruitment for those sorts of roles to connect families to different resources and to really be proactive in saying, do you need this? Would you like this? These are what's available, that what our hospital offers. Because I think a lot of times families are, everyone's focused on the medical, which is incredibly important, but sometimes families are also afraid to ask, like, what is available in the social realm and the mental realm, even financial questions. Yeah, so I think being very proactive, and probably more recruitment of health navigators in the hospital, and help families navigate this unfamiliar situation.